So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Cancer Living Room. For those of you who may not know me, I am Danielle Hicks. I am Chief Patient Officer here at GO2 for lung cancer, overseeing a team of really amazing humans with a lot of expertise, empathy, and compassion. I couldn't be more proud to work alongside each and every one of them, including our very own Michelle Zay, who's monitoring the online chat. So welcome to those watching online, welcome to those in the room. We are thrilled to have you. If you're not familiar with this programming, it actually started in 2009, right? Bonnie Dario, also in the room tonight. Really with keeping people diagnosed with lung cancer in mind. So the very first meeting, we gathered a very small handful of people and just said, what do you want? Sort of a build it, or tell us what you want and we will build it for you. And here we are today, all of these years later. It has, of course, evolved. We were very fortunate that prior to the pandemic, it had already evolved to this. So we were already streaming live so that people could watch from their own living rooms wherever they may be in the country and around the world. We know that this programming is incredibly important to our community because we've been viewed in 144 countries.
Wow.
And I'm not embarrassed to say I didn't know how many countries were actually in the world until that number started getting up, and I was like, how close are we in? So we're really proud of this programming. Tonight, we have with us a veteran to this programming, Dr. Kyle Hogarth. He flew in from Chicago to be here with us today. And we're going to be talking about pulmonary health. I think it's something that we still hear from a lot of folks that we talk to around the country and around the world that they don't have a pulmonologist on their team. And when you think about lung cancer, you should be thinking about pulmonology. They go hand in hand. It is a cancer of the lungs, and the cancer is quite often not the only thing that needs to be treated when you're diagnosed with this disease. So we're really, really excited to have him back today. I'm going to do a quick little, just a title.
Please, yeah, no, short.
Well, I'm going to do the short version, and then I'm going to ask you to introduce yourself and talk a little bit about who you are. But Dr. Hogarth is a professor of medicine, section of pulmonary and critical care medicine, director of bronchoscopy and interventional pulmonary, co-director lung cancer screening program, medical director of the Pulmonary Rehabilitation Program at the University of Chicago. So you wear a couple of hats in your day job.
But there's a unifying function about it.
Yeah. But we couldn't be more excited to have him come back. He did join us, I think it was during COVID, and you were on vacation.
Yeah.
And Dr. Hogarth took time out from the cabin. He had to drive down the hill because the internet went out. He did it from his car. So when I talk about commitment and healthcare providers who are committed to ensuring that we are providing this type of really important information to our community, he's the guy. So before we jump into the topic and what we're going to talk about tonight, tell us a little bit about yourself and why lung cancer is a primary area of focus for you.
So, well, as you stated, I live in Chicago, and I wear several hats. Actually, I'm going to first say hi to my family who was logging in tonight. So,
nice.
Hello, everybody.
Hi, Hogarth family.
Hello, sweet family. My interest in lung cancer basically went hand in hand with my interest in pulmonary medicine, but on top of it, the diagnostic component of it and the management of it, and both in the early stages and the late stages and the complications and everything in between. But I think what always motivated me to be a pulmonologist to begin with is if you can't breathe, nothing else matters. And I grew up with pretty bad asthma, still have it. better controlled now. You'd hope so, given what I do. But, you know, I understand what it's like to not be able to breathe. And it's unacceptable that you can't breathe because we've got better things nowadays. And I think a lot of what motivates me to work in this field, not just on the breathing side, you know, just in general, whether that's COPD, asthma, et cetera, but on the lung cancer side, is that much like, you know, I'm not an oncologist, but much like the therapies for advanced lung cancer have just been leaps and bounds dramatically improving. The same goes on the diagnostic side. And so the things we were doing even a few years ago are no longer relevant. We've got better and better technologies, better and better ways to help, to diagnose, to treat, to be more involved, to work up that nodule. So when you're first worried it's cancer, does it actually have to be? Do you even have to undergo an invasive procedure? We might be able to figure it out without one. Again, depends on the situation. But the point is, everything's evolving and evolving rapidly. And unless the physician you're working with has a specific interest in lung cancer from a diagnostics perspective, so not every pulmonologist is involved in this area, you know, you may be getting sort of 10-year-old advice because that's about their level of interest. It's not their fault per se. It's not their area of expertise. And so, you know, I guess right up front, if you've been told, so for people that are watching, if you've been told there's an abnormality on your CAT scan, so you've not been diagnosed, right? We're not here talking about screening yet or even someone with cancer. You've been told there's an abnormality. Absolutely, unfortunately, it could be lung cancer. But thankfully, there's a whole long list of other things it can be. So before someone decides to just cut you open, let's get a little bit of smartness behind this and figure out whether or not you actually need even an invasive procedure. What kind of invasive procedure? We've got better data on that as well. And then if it is, make sure they're doing it right to get enough tissue to figure out how we're going to treat you in the first place. Yeah. And did they actually stage you at the same time? So anyway, that's what motivates me because, like, I get beyond frustrated. Patients come to me, they've already had a kind of procedure done, but not the complete one. So now we've had to delay, wait, and have to get another procedure.
Yeah, and I want to dive a little deeper into the diagnosis sort of piece of this.
Sure.
We know that screening is available for lung cancer, but it's really limited when we're talking about who qualifies, right?
Correct.
So, you know, 50 or older, 20-pack year history, have not quit within the last 15 years. We also know you don't have to smoke to get lung cancer.
Correct.
We'll take it right now because it's only been in the last decade or so that we've actually had screening available. And, you know, those of you who are regular to this living room, you've heard me say this before, people who watch this meeting are well past this screening sort of conversation.
Right. But their friends aren't.
Their friends aren't, and that's my point.
Or their family members.
And who better than somebody with lived experience to have this
100%.
Conversation with people. So, but it's not just through screening. Sometimes it's an incidental finding.
It's actually more common, right? So lung cancer screening is still sadly in its infancy and has been very poorly adopted. It's actually one of the states with the lowest lung cancer screening rates. It's California. And so, not that Illinois is much better, but all kidding aside, there's, you know, you get frustrated by that. But then you look back at the rate of adoption of mammography as being standard of care, and there was a journey. And it's still not at 100% like it should be, obviously. And so, you know, we can do better, no debate, and let alone define better who should be screened. You know, so we're still in our infancy, and rightfully so, no one should be happy with where things are at. Sure. Now, incidental cancers, meaning you got a scan for a completely different reason, and there's a nodule, by the way, that is the major source right now of lung cancer screening, if you will. Mm-hmm. And it's the major source of where we find people, thankfully, at early stages. But, you know, quite literally the patient who told me their car accident saved their life. Because the car accident is what found the nodule that turned out to be the primary lung cancer that they had no clue that they had. And they had no risk factors. They never would have been a screening patient. Yeah.
So when we're talking about nodules, however it may have been found, and you touched on this a little bit, sometimes and more often than not, they're benign. It's just a...
I think one of the things that came out of the lung cancer screening trial is that, you know, so these were considered, quote, high-risk patients, whatever that means, but, you know, a nodule in a patient that's in this study would have always raised major concerns. But the vast majority of the ones that were found were not cancer. So you start with that. So even a high-risk population. Now, look, there are things about a nodule. With the word nodule is unbelievably benign. That's like saying human. That doesn't describe anything about anyone in this room beyond that, right? And so what's the size of it? What's the shape of it? What are the risk factors? Where is it located? Is it spiculated or not? How old is the patient? Those all matter. They all are a component to it to take that risk that it's cancer and raise and lower it, And at some point, there's a threshold where we say, the risk is now high enough that it's my advice to you that we need to start doing something more than a watch and wait because it's too risky to watch this. In other scenarios, I will jokingly tell patients to sort of break the ice and say, part of my job is to protect you from people like me. Because people like me do biopsies. I like to do biopsies. Let's be straight. I like doing biopsies. Which reason I'm hyper aggressive about this. So when I tell you you don't need one, you can believe it. And I kind of jokingly say, I'm here to protect you. Because the health system wants to biopsy you, right? Automatically. And a lot of nodules do need one. But a significant amount can be watch and wait.
Yeah, and I think it's important to note that this surveillance or monitoring of these nodules is relevant prior to a diagnosis and then after a diagnosis as
Absolutely.
well. Yeah.
No, so after a diagnosis, of course, depending on your treatment and what's the stage and so forth, there'll be a period of time where you're going to be getting fairly frequent scans to ensure that you are cancer-free. And then after a period of time, those get spread out further, thankfully, because you've proven that you are cancer-free. But they should still continue. Now, at what rate? No one knows. Because unfortunately, until more modern times, we've not had a large cohort of people that have been cancer-free because we found everybody very late stage and our therapies were awful. That's thankfully all changing. The therapies have gotten better for all stages, right? This is one of the most wonderful stories behind lung cancer. What's evolving, but you need to always continue to be monitored. And watch and wait. I understand why people, if you don't mind me
Please.
Pausing for a second. So like when we see a nodule, there is a workup for it. There's some various blood work that can be done. There are various other scans that can be done. Your original scan may not have been actually the correct scan to look at a lung nodule anyway. A cardiac scan, for example, doesn't look at the entire set of lungs. It just looks at parts. So when they find a nodule on your cardiac scan, you still need a new scan. But when someone says, well, wait, if you think it might be cancer, why are we sitting on this? So depending on the size and the shape, there are plenty of reasons that we should watch this. The other, or that doing a biopsy may be challenging enough that the risk to you is higher than the actual risk that this is a cancer. But the frequent conversation I will say with my patients, especially for the smaller nodules, say, well, let's just assume I'm wrong, that this is a cancer, that I'm telling you to watch this thing, idiot that I am. So what's going to happen in 3 months when I repeat your scan? This 9-millimeter nodule, well, it'll be 11 or 12 millimeters, and it'll still be stage 1, and you will still be cured of it. But the other 990 people that I told to watch and wait, it will not have grown. And so they all avoided unnecessary procedures. So we actually lose nothing for, again, very specialized scenarios. This is not a generic thing. But as the technology has improved for us to be able to do biopsies, our threshold to do a biopsy has indeed lowered. So if you have a scenario where the nodule is in various locations of the lung, even if it's relatively small, we can sample that now pretty reliably and pretty safely. There are people with that expertise. It's not just anybody. You definitely need to seek out the right physician to do this. But we can actually put it at rest. And that comes back to what's the actual risk that this is a cancer, right? And there are these nodule calculators that we use to give us at least 1%. And it's not perfect. But if I tell you your chance of cancer is 1%, but your chance of complications is 1%, right? But if I tell you your cancer is 4%, 5, 6, what's your threshold, right? And of course, it's not just a generic answer because depending on the patient in front of me and how healthy or unhealthy they are, a 4% chance of cancer is not something I feel like we should sit on. But if you're not medically able to undergo a procedure, we might be forced to sit on you for a little bit because it's going to be too risky.
Yeah. And again, this is relevant at original diagnosis and again
Correct.
At progression. So I think that's why it's important that folks watching, if and or when there is a concerning new nodule.
Absolutely.
This is the type. The scenario is the same.
Well, and the reason you want to see someone who does what I do is that, so you're a cancer survivor, you're 3 years out from your lung cancer diagnosis, and they're scanning you, and now you have a new nodule, and it's 6 millimeters, and it wasn't there last year. Oh, dear God, my cancer's back. Or worse, it's a new cancer, or any other scenario. Yep, I understand your concern. It's 6 millimeters. We can biopsy it. It's challenging. So what we always do in that scenario, we say, we're going to get a new scan in 3 months, because typically scarred lungs, or if your lungs do have emphysema, small nodules can appear as from a mucus plug. And then when the scan on the next one, it's gone, Aren't you glad we didn't cut you open? Aren't you glad we didn't do a procedure on you for a nothing? So it's understanding where the fear is, and if you don't see someone who understands how to work up nodules, they will play into your fear, and you will go through a lot of unnecessary procedures.
And I think it's really important. I think this is a good sort of segue into how far we've come from a diagnostic standpoint and a technology standpoint. Because I think a big fear prior to such strict guidelines around nodule management and what that looks like and what the follow-up looks like, big concerns were, the risks of collapsing a lung because you're, sticking a needle through somebody's back, and the risk is really high. And again, you need to breathe, right? So let's talk a little bit about some of the newer kids on the block. What does a biopsy look like today? Not that FNAs or needle biopsies aren't still done, but
well, they're done less and less, and actually they're done less and less because it's been proven now that as far as outcomes come, they're at a minimum, they're no better than a bronchoscopy. So that nice study just published, if you randomize people to bronchoscopy or needle biopsy, the outcomes are the same as far as diagnosis. The complication rates, though, are markedly different. Needle biopsy, the lung's a balloon. You're going to stick a needle through it. What's the chance you're going to pop it? A lot. The chance of popping it from the inside is about 1%. We wish it was 0. But ask any person, do you want a 1% chance of a complication or a 20%? No one signs up for 20. If you're in an area that doesn't have a bronchoscopy program that can sample lung nodules reliably with one of the robotic platforms that are out there, then go see someone else. The thing that drives me the most nuts, I remember once I had this discussion with one of my parents' neighbors, and I said, and my parents lived at the time in the middle of nowhere, and I said, you need to go there. And the patient said, ugh, that's a 2-hour drive. And I was like, your life's not worth 2 hours?
Yeah.
Like, are you kidding me? By the way, where they lived, it takes you 30 minutes to get to the stupid grocery store.
Yeah.
So like,
what's the next think
of the big grocery store where you're going, So I was just like, come on. I didn't say you're going there weekly, right?
Yeah.
You're gonna go see someone and get the correct diagnosis.
Yeah.
But the other thing that's important, and the reason why needle biopsies, in my opinion, need to be used less and less and less and less. And there are still scenarios where we send people for needle biopsy. There are specific spots where it's easier, or in some cases, if we're backed up enough, just quicker. If I can't do your procedure for 2 weeks and that guy can do it in 2 days, let's just, and it's a slam dunk for them, let's go do it. But they don't stage you. When we do a bronchoscopy, we sample your nodule. We have pathology in the room. God forbid we prove it's cancer. The next immediate step that everyone asks is, well, what stage am I? And you know how good that PET scan is at telling you what stage you are? About 90%. You know what? My patient deserves better than a 1 in 10% chance that their cancer spread. So we go and sample all your lymph nodes while we're in there to prove that they are indeed negative, and they usually are, thank God. And now I can send you to the surgeon or radiation with the confidence you're a stage 1 lung cancer.
Yeah, and I think biomarker testing and quality and access
Bingo.
to quality tissue is a huge piece of this too. Again, really relevant at diagnosis and any progression.
100%.
So let's talk about.
Can I actually even more than progression? Because nowadays, 2 things have come out more and more. So obviously, you keep hearing about all these great new drugs. Well, guess what? There's a whole bunch more in development and coming down the pipeline. But many of them require a fresh analysis for mutations. In other words, you might have been diagnosed 2 years ago, undergoing whatever, in whatever stage, undergoing treatment. And now it looks like you're progressed. So they go, okay, well, guess what? We need fresh tissue. Because you may have new mutations, or you may have the mutation for this fancy new drug that we didn't know existed 2 years ago, but the preserved material can't get tested for it. So about 10% of my bronchoscopies nowadays are to go get fresh tissue from a known cancer patient, and you know the nodule or the lymph node's full of tumor, but we gotta go get more so we can get them on a new therapy. And then that works, and then you don't see them again for another year or 2, thank God, until something else pops up, and then you go after that.
Yeah.
And so, and the goal here for everybody, I don't want to speak for the oncologist, but I know what mine say, is that for the people that we can't, quote, cure, the goal is to then keep it so suppressed that it becomes like where HIV is now. Yeah. You just have it, but whatever, take your meds, and that's the dream. If we can't cure it, can we at least contain it and just, keep it at bay?
Chronically manage.
Yeah, chronic manage.
Yeah, I love it. So let's talk about this, this type of bronchoscopy.
Yeah.
What are we talking about?
So it's pretty straightforward. It's done under anesthesia. So, you're out cold. You don't care. We go down with a robotically driven scope that allows us to snake our way into the far reaches of your lung. The CAT scan you had allows us to build a three-dimensional map of you, much like a GPS, and we can drive to where we need to go, pass our instruments through, take our samples. Because we have pathology in the room, at least the good sites do, we also know that we, A, make a diagnosis, but more importantly as well, because we kind of assumed that this was a cancer, did I get enough tissue to run the molecular analysis, right? My job 15 years ago was real easy. Is it cancer, yes or no? And is it small cell, yes or no? And that was it. If I had 100 cells that said you had cancer, my job was done. Now, if I don't get thousands out to run the molecular analysis, to truly fingerprint your tumor, then I haven't done my job. Because just telling you have cancer isn't good enough these days. And yes, there are blood-based ways to look for mutations, but they all have their ups and downs. So does tissue. In the end, we're going to run all of it, right? We're sending the blood, sending the tissue. We're going to find something to try to do different for your tumor.
Yeah, I think that's a great point because we talk a lot about liquid biopsies in these conversations as well. And although they've become an amazing tool, particularly when they're run in tandem with tissue, but tissue is still considered gold standard, which I think is important.
Tissue's the issue.
Yeah. If we see something in the blood, we know it's there. But if we don't see it, we're still not sure that.
Well, and how do you know it's in that place we're sampling, right? I mean, so you have a nodule, that nodule that pops back up on a patient. They say, oh, your blood turned positive. Well, how do you know it's that nodule?
Yeah.
The oldest rule about making assumptions, right? So, and especially, again, all around the country, there are endemic fungal infections that look just like lung cancer. PET positive, spiculated, growing, all throughout. Anything that basically drains off the Mississippi, the Ohio River, and the Missouri River, and everywhere else, north and south, and pretty much now, because of climate change, extending everywhere, is histoplasmosis and blastomycosis. And coccidiomycosis is down in Arizona, New Mexico, and most of California. And so nodules don't have to be a malignancy. I mean, yes, we should worry about that, but there's very much a benign thing that can happen. Yeah. The other reason that the bronchoscopy has become even more important, besides obviously less invasive, besides outpatient, low complication rate, the ability to stage at the same time, guarantee you get enough tissue because again we have pathology, at least the good sites do, that to give you immediate feedback, is that we can leave a marker behind to help guide a surgeon if the surgery is the next step. And then equally important areas of research that are going on that are super exciting is the ability to try to treat it while we're in there, or at least prime the immune system while we're in there. Get it juiced so that if they're going to put you on a checkpoint inhibitor, we've already helped to take care of it. And and look, it's pretty premature to claim, this one's good or that one's bad or this, but the research is happening, right? Yeah. And the idea that we would be able to, maybe someday, the goal would of course be to cure it from the inside. But until that happens, how about I at least get things rolling on the inside, right?
Yeah.
And I think the other reason also, to kind of even add more to this about why it's so imperative to get staged properly, is that more and more studies just came out, especially in this, and were presented at ASCO this year. The role for what it's called neoadjuvant. So in other words, if they operate on you and they go, oh gosh, you're stage 2, one of your lymph nodes was involved. You're going to need therapies on the back end after surgery, and that's been the standard. And they do better than if you don't do the therapies. But guess who does amazing? If we treat you before we go to surgery. So we prove you have a cancer. We prove you're not stage 1, you're stage 2. And we give you all these targeted therapies, the checkpoint inhibitors, the therapies guided towards your mutation. And then 3 months later, you go to surgery, which sounds crazy, except the data shows you're going to do worlds better. So crazy as it sounds, sitting on your cancer, you're not. You're getting drugs to kill it. You do better. Yeah. So it's not relevant anymore to just hope you're not stage 2. Yeah. I got to know you're stage 2 before I'm going to send you to the operating room.
Yeah,
and that's a huge shift.
It's a huge shift, and it's over the
last
couple of years that therapies have been approved and or are really in clinical trials.
Well, all these studies keep getting done because, of course, thankfully, thousands of patients volunteer to be in them.
Yes.
Right?
Yes.
And so that we can keep moving the field forward.
Yes, and
there is a question on the couch.
I'm the queen of praising all of our clinical trial.
Everything that I do today was built on the shoulders of volunteers.
Yeah, it's true.
I have a question about using bronchoscopy for staging. I'm assuming that the instruments that you use just go into the lung, so you're not biopsying, say, lymph nodes outside of the lungs, are you?
So what we do is if we do use the robotic scope to biopsy, let's say a nodule in the upper part of your right lung, okay? So and your CAT scan and or PET scan say, this is the only place we believe your tumor to be. No, of course, we don't even know it's a tumor yet, but let's say we prove that. So this tumor likes to spread first to these lymph nodes and then to the lymph nodes in the middle of the chest. That's the typical spread pattern. Yes, cancer can do whatever it wants. It does jump around sometimes. But relatively speaking, it goes from here to the lymph node at the side of the lung into the middle of the chest. So once we've proven this is a cancer, we put in a different scope that has an ultrasound on the end. And that ultrasound scope allows us to go and see, we know where these lymph nodes are, we see them in real time, we pass instruments into them, remove pieces there, and look at that under the microscope. And that's where we go, oh, you're stage 2. Fine, that just is a different pathway. Oh, good, no, they are stage 1. That, we're gonna go see a surgeon, and by the way, that's only gotten better too. So the number of people who are non-operable for medical reasons, meaning, oh, your lungs are just way too bad to tolerate a surgery, that number keeps shrinking as well. As surgical technique has kept getting better, as it's been proven that we can take out less lung and people will still do quite well. So between the surgeons and the data behind what we need to cut out, there are still people that are non-operable because their lungs are, unfortunately, too beat up from emphysema typically, or other diseases. But boy, oh boy, that number keeps getting smaller and smaller. So that's one of the other things I'll add. I'm not a thoracic surgeon, but please see a thoracic surgeon. Not a general surgeon, not a cardiothoracic surgeon who spends most of the time working on hearts and dabbles in the lungs. See a thoracic surgeon. And you're like, well, there's not one for 4 hours. Get in the car. Because thoracic surgeons just do lungs, and they sometimes esophagus. Like, these are people that this is what they do. And as you can imagine, everything in medicine is based on volume, right? I do hundreds of bronchoscopies a year. There's a reason why I'm better at it than the guy that does 5. Not necessarily because I'm better, but I got a lot more practice under my belt, right?
Yeah, no, I think that's a really good point, and the staging is so incredibly important for all the reasons that you stated.
Yeah.
Thank you for the question, and I want to remind people, just to take a quick pause here, please ask questions throughout. That goes for anyone who's watching online too. Michelle will grab a mic if anyone has questions. So we talked about nodules, nodule management, biopsies, diagnosis, staging. I do want to share a story. So an interventional pulmonologist who's down the road here, this was back when navigational bronchoscopy was sort of new to the game.
Yeah.
And with a patient's permission, I got to sit in the operatory or whatever and witness this. And I can tell you, I had chatted with the woman before she went in. I did not hang around to wait for her to come out of anesthesia, but I felt like I was in like Star Wars. It was some like futuristic, like with the CT scan up, and to your point, pulling like she had bilateral lesions. One was only 4 millimeters. He got right down in there, pulled from both sides, pulled lymph nodes, and she was, up and out of there, within
a good chunk of what we do has been all built and designed and developed in this greater area, right?
Yeah.
I mean, it's all
agreed.
A lot of this started as Silicon Valley startups. Not all of them. That one you were talking about from the original one actually came out of Israel.
Yeah.
But the 3 robotic platforms that are currently being used in the U.S. are all, in this greater area.
Yeah.
So,
and technology, as you guys know, not only in the area of pulmonology for all the reasons we've already talked about, but across the board in diagnostics, has played a huge role in getting us to where we are.
well, and it's this ability to reliably get, so it's important to get reliably to that nodule, prove it's cancer, mark it, get enough tissue, no debate. But even the dream of being able to offer a therapeutic is dependent on knowing where to put it. I mean, if I'm here to burn off part of your tumor, or freeze part of it, or inject something into it, or whatever, again, lots of things being studied. I got to know where I am. It doesn't do you any good if I'm killing off part of your normal lung while leaving the tumor alone.
Yeah.
Right?
Yeah, for sure. So let's talk a little bit about some of the other treatments. You mentioned some of the newer, speaking of futuristic types of things that potentially are coming down the pike, but let's start with something like fiducial marker placement. Can you explain what that is and what your role is there?
Sure. I mean, the way to think about it is it's X marks the spot. So, when a surgeon goes in, if they're going to remove part of your lung anatomically, meaning just the whole right upper lobe, right? They don't need anything marking. It's in that lobe, that whole lobe's coming out. But what if they're only taking out part of it? And on the outside, the lung kind of all looks the same. And you say, well, it's a solid nodule. But what if it's not a solid nodule? And what if it's in a little bit from the edge of the lung? And remember, they're not going in with their hand anymore. They're going in either with a robotic scope, so the surgeon's on the other side of the room, or a robotic operating platform, or they're doing what's called VATS, so they're basically operating with chopsticks, and their hands are weighted, their hands are here and the fingers are down there, but no one's touching anything. There's nothing tactile. So how do you know where the heck to go? That's where the fiducial markers come in, or dye marking, or other things to help guide the surgeon. And the value of that is multiple. One is, of course, shorter surgical times. Less time on the table, always good. Less amount of lung taken out, but the correct amount of lung taken out. If this is X marks the spot, the surgeon knows to go here and here, right? And then they've got it with their margins. And actually, literally this morning before coming here, I had a meeting with this interesting company out of Japan that, in order to really tag it, has created essentially a smart fiducial. It's an RFID tag. I mean, as in like to keep your stuff from getting stolen from the store and whatever.
Yeah,
It's got the surgeon can put a wand in to put right over where the thing is, and beep beep, it's right there, and it's tiny. I mean, it's this big, right? I leave it in there while I bronch you, prove your cancer, leave it there in the tumor. The surgeon knows exactly where it is, and then can cut out around it.
Yeah. Crazy.
And it's potentially coming to the U.S. That's one of the reasons I was meeting with them. That was this morning before dashing off to O'Hare.
Sometimes cancer treatments can cause damage to the lungs.
Yep.
And sometimes there are comorbidities, as you touched on, COPD, emphysema,
Pulmonary fibrosis as well.
Yeah. Let's talk a little bit about the treatments and how they can potentially damage the lungs and what role you play in trying to support.
Yeah, so some of the therapies can cause an inflammatory reaction in the lung. And the problem is that the inflammatory reaction can look somewhat like an infection. It can also look like progression of your tumor. So you got an oncologist that says, well, there's one of three things. They're all bad, but I don't know which one it is. But they're all treated differently, of course. And since one of them involves stopping your drug, that's, we hope, helping you, that's not something you want to just do willy-nilly, right? Oh, I will just stop your therapy. No, right? Or the other ones involve putting you on pretty toxic drugs to treat it. So some steroids. Don't want to do that on a whim either. And then the other one's pumping you full of antibiotics, if appropriate, right? So where we play a role frequently is to go back in and wash out the lung, and in some cases take biopsies to tease out what's what. And so that's the other reason the pulmonologist is frequently very much involved still with the oncologist. If you have pulmonary fibrosis, there are treatments for that. And hopefully you've been seeing a pulmonologist who specializes in that disease. Pulmonary fibrosis is not something I specialize in. I've got 4 colleagues, that's 5 now, excuse me. That's all they do. That horrible disease, that's all they specialize in. So I had someone like by accident come into my clinic and I said, look, I know the workup they want, but I'm gonna go get you in front of someone who knows what they're doing because it ain't me. And so I immediately put them in the correct clinic.
Yeah, I even think about, and I'm gonna tell part of my mom's story because I know she doesn't care, but I even think about, and she's probably maybe just tired of telling it, and plus I always think I tell it better, or at least more honestly. So her treatment was neoadjuvant chemoradiation.
Yep.
Then she had a lobectomy. She had some repair done to her aorta where they had to peel part of the tumor off, so she had some sort of grafting. And then she had intraoperative radiation while she was on the table.
Yep.
I mean, she's still here 20 some odd years later, which is incredible. But that's a lot,
It
right?
is.
And when I think about not only did she lose, what would be 2/3 of the left side of her lung, there have been a lot of complications since then when it comes to breathing.
Yeah.
So what are some, and I mean, I can't imagine, and I'm certainly not going to speak for anybody, and I welcome anyone to share their experience or their story, but anyone who's had radiation therapy and or surgery in particular, not limited to, but in particular, there's been damage, right?
Correct.
To otherwise healthy lung tissue, and climbing Machu Picchu might not be on your list of things to do.
Right.
So what type of support can or do you provide to these folks to help open up their airways and
Absolutely.
have a good day?
Well, so no one's going to go have an operation on their chest without first having pulmonary function tests, right? Because we need to know what your lungs are capable of. And it's not what you say you can do. I want to objectively know what you can do. And the surgeons are for sure going to know it, because that's what's going to dictate whether they can safely operate, right? Because if we're going to remove 1/3 of your lung or more, et cetera, and your lung function's just barely getting by at rest, I'm going to cure your cancer and you're going to be able to do nothing afterwards, literally. And I don't mean like, oh, I'm going to be limited. I mean nothing. So it won't happen. Now, thankfully, as radiation therapy has gotten dramatically better, it used to be that if we said, we can't operate on you, you're too sick. Radiation was sort of a like, here you go. This was years ago, decades ago. Now, I would make an argument that radiation is kind of neck and neck there with surgery. I mean, there's still kind of a natural, like, let's go cut it out of you. But no one's offering you like a lousy second prize here. It's really good. So like if someone's not a candidate for surgery, with the caveat that they've seen a good thoracic surgeon, they're truly not a candidate, then go get the radiation. And that's gotten better and more detailed and less damage to the surrounding tissues and so forth. Mm-hmm. But our surgeons also will make you go through, because they want to operate on you, but you still have a little bit of time. So they will make you go through what they call prehab. Rehab is after, before we're going to operate on you. Like we noticed, who here is actively running every day? And so people with lung disease tend to be running even less. Mm-hmm. They're like, no, you're short of breath for a lot of reasons. Yeah, your lungs aren't great, but you're not great because you haven't been, and they're like, oh no, I've got a normal weight. It's not about your weight. It's about your aerobic conditioning. And if you want to extend who can get surgery, get moving, right? The other thing is, have you seen your pulmonologist? Let's see your pulmonary function tests show you have pretty decent COPD. Well, what are you taking for that? The meds for that have gotten better and better and better. And we even now have procedures for advanced emphysema. One of the most fascinating things, we do a thing called bronchoscopic lung volume reduction. And it's a limited group who can get this. But the CAT scans that we do to figure out how to do your bronchoscopy look at obviously all the lungs, and we quantify all your emphysema. So I have patients who we diagnosed their cancer in the middle part of their right lung. They weren't great surgical candidates, but we put the valves in the other lung that was where it was really damaged, and their lung function improved enough they could now go get surgery. Or in other cases where the tumor was and they said, you're not a surgical candidate, but that's where we figured out through the other work we do that this is essentially a dead part of their lung. For like, think of a branch on a tree that's dead. So the surgeon suddenly said, oh, well, cutting that out is actually, in the calculus of what your lung function is going to be, this actually, you might breathe, ironically, better after the surgery, as crazy as that sounds, because we're going to quite literally go prune out the dead tree, the healthier part's going to grow. Oh, by the way, we'll cure your lung cancer, a little nice twofer.
Yeah,
but, and again, these are not every day. I wish they were every day, but it's why kind of being very comprehensive about your breathing, whether that's being in pulmonary rehab, do you need oxygen? What inhalers are you on? Are you up to date on your vaccines? My God, you've obviously quit smoking. And that's all smoking, by the way. Marijuana is just as bad for the lungs, just as bad for the lungs. In fact, by some data, more emphysema causing than cigarettes because of how people smoke marijuana, right? Nobody takes a cigarette and goes, and then holds it for the next, right? I mean, so there's actually an argument that marijuana is more toxic to the lung. Who cares, though?
Yeah.
Vaping, too, dear God.
Yeah.
Right? Just when I was hoping I'd be going out of business with emphysema, with smoking rates on decline, vaping and everything else is keeping me plenty busy.
Yeah.
So when I tell people who like marijuana, I live in a state where it's legal as well, just eat it. I have no idea if it's good for the gut or not. I'm not a gut doctor, so I don't care. But it's not bad for your lungs if you eat it. Well, I work in the real world, right? If I tell someone don't do anything, you know they're going to.
Yeah.
So then I find a way that's not going to at least harm their lungs.
Yeah.
But there are better and better drugs that we have, better and better procedures. There are clinical trials. We're in 2 of them right now to offer up better ways to treat their emphysema, if they have that, and so forth. But it's about staying in shape. And you know, if you're going to have surgery, as less invasive as those have gotten, you know, it's a good, you know, our hospital, we keep people in the hospital 2-ish days, and then it's about a week of recovery, and then another week till you kind of feel back to yourself. But then after those 2 weeks, get going. Like, move. You need to move and move again, because you're going to get weird pains in your chest for forever. You're going to know when a storm's coming, right? You're going to turn into an old sailor real quickly because they cut micro nerves in there. It happens.
Yeah.
You're just going to be sitting there. You're like, weird electric shock.
Yeah.
You didn't do anything. It's minor nerve damage.
And
She's nodding, right? I mean, yeah, old sailor.
Yeah. But I think that's really relevant, because I think quite often with the folks that I've talked to, any new ache or pain or something that wasn't there before, it's like, it's the cancer. They didn't get it all, or it's back.
I had an absolutely wonderful patient who unfortunately passed away recently, but not from cancer. He was a 15-year survivor. And I remember it made me rethink how I approach my long-term survivors. Because every time they came to see me, and even if they wasn't a scan, he was just coming for his lungs. But he was the most wonderful, joyous man, and his wife, they were just beautiful. And he would always be sort of on edge, and you know, especially if there was a scan recently. And I told him, I said, look, we're always going to scan you, but it's been 5 years. I said, the statistical chance that your cancer is going to recur is so exceedingly low that if you get cancer again, it's going to be a new one, and you'll be stage 1, and we'll cure you of it. I said, it's time for you to go start living your life again. And that was what I said to him. I said, just like that. And I remember I said that, and I watched him just collapse, like just frump into the chair and just start bawling. And you know, that was the rest of the clinic visit. And it was just, it made me change how I approach people to say, it's time to go live life again. You're not a patient anymore. Like, I know, you're on one level always a patient, but like, live your life again and stop being a cancer patient or a cancer survivor. Though it's important, be a person again, because don't let this be what defines you. Right. And it blew me away, because he was always such a jovial, kind man and happy man. Never saw the stoicism that was also there in clinic until I sort of cracked it, and then you know, and then it was awesome. I mean, in the next 10 years, we're always joyous.
Yeah. So we talked about PFTs, talked a little bit about inhalers. We didn't really talk about nebulizers and the role that they play, or oxygen. And oxygen, not for some, maybe to, walk from A to B, but how important oxygen is at altitudes, and in particular, maybe when you're flying.
Yeah. Because you're living again. You're supposed to go places.
You're supposed to go places. And most people don't realize that the cabins are pressurized around 8,000 feet, and that's pretty high. So how important is it that people not just get pulmonary function tests, but also an altitude
Well,
test?
or at least a walk test to see if you desaturate, right? I mean, walking up and down the hallways, like until you tell me you're short of breath, or a 6-minute walk, measure your oxygen. Let's just go ahead and say it right now. I understand why everyone hates oxygen. It is a definitive outward sign that you're ill, right? It says to the world, I'm ill. And everyone just assumes it's because you smoked, because that's the stigma, right? So it's like a double whammy. Like, oh God, she's ill, and here's why, right? So I get it. And it's cumbersome. There's no such thing as a light oxygen system, and so everybody hates it. I get it. Except here's the problem. If you have low oxygen and you don't wear it, you're gonna die. The studies show it. You wanna live longer? Wear your oxygen. There's nothing more challenging than that. And my favorite statement, so let's debunk it right now, I don't want to get dependent on it. I'm dependent on oxygen. Everyone in this room is dependent on oxygen. The minute you were conceived, you were dependent on oxygen. You do not make yourself stronger by robbing yourself of oxygen. You actually make yourself weaker. It puts a huge demand on your heart and on your brain. It is an increased risk for a heart attack and a stroke. You're going to go through all this garbage with lung cancer and fight your way to the end, and then die of a heart attack that was preventable? Oh my God, like that's not fair.
Yeah.
And then you could have prevented it.
Yeah.
So, you know, and that's the other thing. I mean, we were talking about lung health though, but I see this all the time as people are going through a cancer journey, especially if there's an advanced stage cancer and they're getting lots of different therapies and all the toxicities that are associated with that. As I watch the rest of their health get completely kaput. Oh, I don't need to go see the heart doctor. I'm going through cancer. Okay, but you still have a stent in your heart, you know, let's say. Oh, I don't need to get mammograms. I'm going through lung cancer. Yeah, but breast cancer still happens. When was your last colonoscopy? And then let's just add to this. So that's the patient who's busy ignoring their health. And don't even get me started on the caregiver. It's usually the spouse who completely ignores their health while caring for their loved one, right? And so their loved one's going through their journey, and then I watch him or her have a heart attack or get prostate cancer or whatever, right? Because they ignored the rest of their health. Because life, unfortunately, life doesn't decide to go on pause because you're on a lung cancer journey. And you go through all of this and then to have something else be the problem that you could have prevented. Because that's the other thing. So your breast cancer now presents advanced stage. I mean, we're talking about lung cancer screening. We found you early stage. We're getting you treated and cured. And then something else you could have prevented is what's now killing you. Yeah. Are you kidding?
Yeah. Yeah, no. Very, very true.
Which is why your COPD matters, which is why you see your pulmonologist. You see us because also if you have advanced cancer, sometimes you get pleural effusions. You can't breathe because you've got fluid in your chest. Let's get it out of you. We can drain it out of you. We can permanently drain it out of you because you should be able to breathe. Even if someone tells you you have super advanced lung cancer, we've run out of therapies for you. You still don't need to be suffering. Is the tumor occluding your airways? Can we debulk that tumor? Can we stent that tumor? Can we help you breathe better for however long that is? It was full circle for me because I took care of a gentleman whose tumor, unfortunately, had eroded through his trachea into his esophagus. And, so anytime he ate, everything went into his lung. It was miserable. And he was on a ventilator. And so we went in and put a stent in so that we could open up his whole trachea, but put an armor over it, right? So that nothing from his esophagus popped into his trachea and vice versa. He could breathe. Now, none of this treated his cancer. He had advanced cancer. He was dying of his cancer. But we got him off the ventilator, and he lived another 10 months, and he ate the entire time, which is all his son said he cared about. And he told me all this because I didn't know this, but his son was a chef, and we threw a party once and hired him. And he goes, "You don't remember me, but let me tell you about my dad." Aww. And it was amazing, right?
I love
that. So where does the pulmonologist play a role? Even when they tell you there's nothing else for us to do from a cancer perspective, and I hate when we have to get to that, but that happens, right? There's still things that we can still do for you, depending on what your cancer's doing to you from a breathing perspective.
Yeah. Quality of life is important, whether you're looking at end of life or just the rest of whatever your natural life is.
And if you have advanced emphysema as part of your lung cancer, and between the two things, you're now at a stage where you can't breathe. It's just the scariest feeling in the entire world. That's again where your pulmonologist plays a role. Between palliative care and the medicines we can use to take away that air hunger feeling, no one needs to die feeling like they're suffocating and drowning. Yeah. So we can fix that. Yeah. Again, I mean, I don't mean to get doom and gloom, but there's a wide spectrum, and there's all kinds of people I'm sure watching who are unfortunately on the far end of where we want them to be, and and so I want to address all of it. Yeah. Because the whole thing is, does the pulmonologist matter as part of your care team? I'm just supposed to diagnose your cancer and then kick you to the curb.
So that was going to be my next question. So setting aside, oh, yes. Hi, Betty.
Oh, sorry. The chair, I feel bad. I apologize. I got my back to half the room. I'm sorry.
So rude.
I'm not trying to be rude.
No, you're saying wonderful things. Thank you so much for being here. My question was about emphysema or COPD. My dad died of emphysema. My mom died of COPD. I'm the only non-smoker in my family. I got cancer. I got lung cancer. But I have a lot of emphysema, a lot of lung disease in my family. Is there a connection?
Great question. So, yes. So let's start with some of the things that are part of the workup for COPD and emphysema. So pulmonary function testing, obviously, and chest imaging. And we should clarify one thing, that you can have emphysema on your CAT scan, but not necessarily have much in the way of bad pulmonary function. In the way, the analogy I would tell you that is, and because emphysema represents damage to the actual lung, but if the pipes where things are moving in and out are still working great, That's how you will have almost no COPD, but still have emphysema. And the analogy is a car that looks amazing or works perfectly, just scratched all along the doors, right? So looks kind of ugly, but works great. So who cares, right? So that's where some people's emphysema is. It's on the scan, but not necessarily relevant to their health. However, how could that be? So up front, there is a genetic predisposition to the development of emphysema and COPD. The most sort of obvious one is a genetic disorder called alpha-1 antitrypsin deficiency, which I bet everyone in the room has not heard of, but everyone in the room who has been told they have COPD and emphysema should have been tested for. And the problem is that the majority of physicians do not test you for this. It is not as rare as people think. About 5% of the United States is a carrier for the disease, so build out your family tree. Think of how many families have married in. I love it. God bless you.
They've all had.
That's right.
Yeah.
But the thing about alpha-1 testing is it's a genetic disease, so you either have it or you don't, but there's treatment for it. So it's relevant, and because it's genetic, it's relevant to your whole family tree. But when you don't have that disease, there is a genetic predisposition that's not well understood. It's pulmonary's little secret that not every smoker develops lung disease. Actually, 75% of smokers don't develop lung disease. We don't want anyone to know that. We like that everyone thinks cigarettes equal lung disease, so we get people to not smoke. But the truth is, if you have lung disease, it's from smoking, secondhand smoke, and or pollution. And then, the grand debate about what causes lung cancer in a non-smoker, there's some things that have been worked out. Radon is one, but in the absence of radon exposure, which is becoming more of a problem because we live more of our lives in basements or rec rooms and whatnot. That used to be where the coal got delivered, where you stored your root cellar and whatnot. But now it's your game room, and so you're being exposed, or sometimes your guest room, and you're being exposed to it. But outside of that, it's still unknown. So that and we keep hunting for the sort of proclivity to lung cancer gene, and a lot of great work going on, obviously, but nothing yet definitive. Like breast cancer as an example, where there's the breast cancer gene. So your lung function testing would matter, and then get an alpha-1 test. Because you probably had secondhand, I assumed your parents were smokers, both from just that age, everyone did. So you had secondhand smoke. Look, we all had secondhand smoke, even if your parents didn't smoke. If you flew on an airplane, you had secondhand smoke. Right? If you went to a bar, you had secondhand. You went to a restaurant, you had secondhand smoke. I mean, it was impossible to avoid. It was everywhere. Actually, the first successful lawsuit against the tobacco industry was the flight attendants union. Because these men and women, more women than men, lived in a metal tube for a good chunk of their life. And they weren't smokers, but they were smoking, in the air. And they had lung cancer rates that were way higher than anything expected.
Yeah, interesting. Michelle, did you have a question online, or were you just trying to get me to Betty? Okay. I'm trying to be mindful of time, but I guess what I want to know from you is, how often should someone be seeing you?
Yeah. Well, at a minimum once a year if you have a lung disease, right? I mean, and now, look, if you are in cancer surveillance, like, you've been cured, sometimes the thoracic surgeon keeps seeing you for the annual scan, right? You're out of that initial period. And so in some cases, the thoracic surgeon says, well, I got nothing to do for you, so go see that guy. And so it's sort of who's taken ownership of your surveillance. But, if you also have an underlying pulmonary condition, say COPD, emphysema, the frequency in which you come to see me is somewhat dictated by the level of your disease. Very mild disease, it is once a year. More mild to moderate, twice a year, sometimes 4 times a year, and then, it just depends on your level of illness. Obviously, we're seeing you more frequently if there's direct management going on of complications related to lung cancer, pleural effusions, need for a stent, et cetera. If there's a stent placed, we're seeing you pretty frequently because of complications from stenting. So it's just dictated by that. But I think the key is, my job is not just to make your diagnosis. It is to be a part of your journey. And if nothing else, to also help guide you along. Right? You can call the thoracic surgeons and say, I've been diagnosed with lung cancer, I need to see someone. And, I don't know what the general wait time is, but if it's longer than a week, that's not acceptable. So I'll be making phone calls, right? Within my system. Now, that part's easy. My whole group, we all see patients on the same day. Like, they're on the 5th floor, I'm on the 4th floor. If you need them, we just whoop, up you go, right? It's a non-issue.
think we have one more.
Yeah.
Oh, we have a couple more questions.
No,
So
yeah.
There's one over here and one over here.
Okay, please. Yeah.
So many that are out there.
Oh, yeah.
There's tons of companies.
Yeah.
Pulmonologists, because in the field of lung cancer, in the world of lung cancer, predominantly you're going after oncologists.
Right.
You're only focused on them, or you're focused on thoracic.
Right.
So
No, so what a great question. So I'll tell you one of the ways in which the pulmonologists have become very involved, and not just on the clinical trial side. So when I diagnose lung cancer in my bronchoscopy suite, right then and there, I send blood biomarker testing because that takes time. So let's get that journey started because the final pathology will be back a couple days later. The tissue moleculars will be a little bit longer. So if you waited for all the data, I've been just told you have cancer at whatever stage, and now you're going to wait like 3 weeks to start therapy? I don't think so. And so one of the reasons we send a particular test called IQ Lung because we get the results in 5 days. And so I diagnosed your cancer, and 5 days later, as you're more or less getting into the oncologist, we already know what mutations you have, actionable mutations. So that's where I think the oncology companies need to be playing a heavier role on the pulmonary side because we're not the gatekeepers, but if you wait till you see oncology, however long that is, and then they draw your blood or send it. So the other thing, like we got rid of, I've run into scenarios where the tissue goes to the lab, and the lab does not run it for mutations until the grand oncologist says so, which is the dumbest thing in the world because another week or two has been wasted. And so our lab, we fought that off a long time ago. It's just automatic. Every lung cancer that I send down to the lab gets automatically run for moleculars. And I'm not done with your biopsies until my pathologist who's there in the room says, I got enough tissue to run moleculars. And so, so that's, I think, the front end of it. I think the clinical trials, there's so many different ways to do them. I think one of the other things we've been looking forward to are better tests, some that are coming to market, some that are at market, some that are under investigation. There are markers that you can start to pick up to predict who's going to more likely recur. For a stage 1 cancer, we're going to cut this out of you. Why is stage 1 cancer not 100% cure rate? Right? True stage 1. I'm not talking about assumed stage 1. Well, every tumor is different. So unfortunately, some people's stage 1 tumor is ridiculously aggressive. This is actually why we want the trials to try to prime the immune system so we can get things going and start killing before anyone's even cutting it out of you, right? But who? And that's been the other issue. So I think that's where, understandably, the people that prescribe the drugs are who industry is going to target. I get that, but they need to think beyond that because especially, and I think this will happen, because as the role for some of these drugs keep creeping out, first it was all stage 4, then 3s, now it's 2s, it's coming, stage 1s. Which will be great, because then they're going to be dependent on me, right? And I'm going to be the one prescribing that chemo in the bronch lab, right? Or injecting mystery drug X in the bronch lab, or putting some kind of nanoparticle to enhance your radiation effect, or hitting it with some kind of a catheter that destroys part of the tumor, creates this massive release of antigens, and your immune system goes insane, and then kills any of the micromets further downwind. And so, again, all hypothesis. I'm conjecturing and hoping. But all I've learned in the last 10 years of lung cancer is everything that I had assumed before is completely wrong. And I've been so happy to be wrong because, it was historically a pessimist's game. And it's now unbelievably an optimist's game. And it's wonderful. And I don't mean to be game. I'm not making light. I just realized I said game and the word cancer in the same sentence. But you get my meaning.
Hi, yeah. I wanted to ask you, oh God, of course, wait, I blushed, just blanked out.
Well, that's okay. I'll come back in.
My oncologist, I asked him, hey, can I get a referral for a pulmonologist?
Yeah.
Because the folks at GO2 for lung cancer says, everybody should have a pulmonologist. And he said, oh, really? We don't do that here. So do you have any, yeah, really. Do you have any tips?
Yeah. So, it's understandably, there's a value to having sort of all your doctors under one roof at this clinic or that university or this hospital. Naturally that sort of makes sense. But depending on where you're getting treated, they may not have all the resources, which is a shame. But there are multiple resources to go find. Any person who does advanced bronchoscopy or interventional pulmonary, by definition, cares about lung cancer and cares about lung cancer patients. And so you can either go to the Society for Advanced Bronchoscopy or the American Association of Bronchoscopy and Interventional Pulmonary that lists its members, and guaranteed there's one near you. And even if there isn't, again, your health worth the 4-hour drive or, whatever, right? And so, and then, it's worth, even if you ask your oncologist, none in our group do, say, well, then where do you send people for your biopsies, right? Because if they're just a biopsy jockey, then they're not really a pulmonologist either, right? I mean, they're just a glorified technician, right? I mean, my job is to not just make your diagnosis, right? I was a pulmonologist in general first before becoming a proceduralist. So.
And we're also happy to.
Sorry, the very obvious source.
Help you navigate any challenges you're having getting in.
The extremely obvious source.
Yeah, I hated that story so much. We'll do anything we can to help both of you.
No, I mean it's crazy. There's not enough of us. The numbers are growing in pulmonary medicine doctors who specialize in lung cancer, both diagnostics and treatments.
Yep.
The numbers are growing, and it's a good thing, but there's still, unfortunately, not enough of us. I'm still shocked. There are parts of the U.S. where if you get told you have a lung nodule, we don't know what it is yet. They send you to an oncologist. So, what? And the oncologist figures it out. And we're like, well, but you don't have cancer. Like, you're an oncologist. We're building an entire new cancer hospital at our place, at our university. The whole building's only going to be devoted to cancer. And they said, do you want to have clinic there? I said, absolutely not. Like, I don't know if these people have cancer yet. I don't need them walking into the cancer building to go see me. Yeah. I'm going to be the guy trying to tell them maybe they don't, because frequently they don't.
Yeah.
Like, no, I'm not going anywhere near that building unless I'm needed.
Yeah. Yeah, I think in, that story about people being sort of sent to the wrong place, and again, you guys have heard me say this over and over and over again, not everyone has the benefit of being seen at University of Chicago.
Right.
Or Academic Center XYZ, or NCI Center XYZ.
Right.
80%, the reality is 80% of the people in this country are seen in the community setting.
And that's okay, there's a lot of amazing doctors.
100%, and I'm not discounting it, but I think it for me anyway, it points back to your earlier point and how important it is if you don't have a specialist in your general vicinity, drive 2 hours to get that opinion.
Absolutely.
And then you can come back to your community and your docs can work together.
Our place frequently does that.
Yeah.
I mean, a significant amount of lung cancer is relatively protocolized. You're stage 3, you're going to get this, and we'll get another scan. Then, so that, my place, our chemo's the same as anyone else's. Like it's not. Yeah. You have to drive 2 hours to get our special chemo. They got the same one over there.
Yeah. Right. I still hear it quite often, and it's so disheartening for me, and I can only imagine for the people diagnosed and their loved ones to either be told, sorry, we don't do that here, or to feel bad that they're going to hurt the feelings of their treating physician. So even though I'm not happy here, I don't want to upset anybody.
I'll give you a quick opinion on that one. If your doctor's threatened by a second opinion or you seeking any other guidance, get rid of them. That's already an incompetent physician. So I have patients I've given a bad diagnosis to. They said, we're going to get a second opinion. I said, please tell me I'm wrong. Like, please come back here and tell me how wrong I was, because I just told you something horrible. I said, I want you to go get another opinion. I hope in God I'm wrong, right? And so, good Lord, if the doctor's threatened by this, first of all, they are then an incompetent physician, right? Because why should you be threatened by something your patient wants, right? And you should always hope you're wrong, right? Because I only tell people bad things. So I love being wrong, right? If I've told someone I think you might have cancer and I go into a bronchoscopy, I tell them my goal is to go prove that I'm wrong and prove you don't have cancer, for example.
Jane?
A little bit about ground glass.
Yes.
I happen to have a lot of it,
Okay.
and I'm wondering what you think about that.
Yeah. So when we talk about lung nodules, we are talking about something solid, but a ground glass opacity is a different beast. And we've always known about them, but we know about them a whole lot more now because CAT scan quality has gotten so much better that they're impossible to not see. So they represent a spectrum of a disorder from some abnormal growing, and the analogy would be like a polyp in the colon, a pre-cancer. Not a cancer, but something we're worried about, to ones that are then now becoming invasive and are starting to essentially form a nodule is the way to think about that. And I'm oversimplifying it, but the reason why GGOs, ground glasses, GGOs, are watched more than they're poked at and resected, not always, but the reason they're watched by default is if they're a pure ground glass and they're small, their risk of spreading anywhere is low, super low. Now, and the reason you have to follow them for years is because they grow so slow. But if a ground glass opacity, even if it's not grown in size, but has become more dense, so then on the scan they say now it's a semi-solid, that needs to get biopsied and or cut out. The probability that a semi-solid is become an adenocarcinoma is through the roof. Nothing's 100%, but it's darn close. And so a pure ground glass, one of the reasons they get watched, especially if people have multiple, is if they're not evolving, if they're not growing or becoming more dense, they're not doing anything. And the analogy is, you frequently hear now, hey, my father in his 80s got diagnosed with prostate cancer, but the biology of his tumor from the sample they took, it's slow growing, it's never going to hurt him. Like 20 years from now, if we're lucky, right? He'll be 102. And so they say, we're going to leave it alone because I can tell you I could go cure him of something that is never going to harm him, but do a lot of damage to him if I cure him of his prostate cancer. Or go cut out a lot of your lung and cure you. Oh, look, it was a lung cancer, one that will not change for the next 20 years. So why would I have cured you of this? So it's an evolving area because we don't know how to predict yet who's are going to evolve, so we're forced to scan you every year. The big area that we've wanted to explore, and a trial got started years ago, but couldn't recruit anybody, was called chemoprevention, meaning we've got multiple ground glasses. We know they all are at risk of developing and becoming a cancer, even if they're not yet an invasive cancer. So could we give you, think tamoxifen for high-risk breast? Could we give you drug X to help prevent them from growing or to prevent them from becoming a cancer? The problem was that we couldn't get anyone to essentially volunteer to take a drug with toxicity. I get it, I get it. So that's where we're stuck right now. So there are a lot of people with ground glass opacities that are being watched appropriately because if in 5 years it goes from 7 millimeters to 8 millimeters, but never becomes semi-solid, what do you think it's going to do in the next 5 years? It'll become 9 millimeters. And again, why am I going to go cut you open? Even if I could have the magic eye that says that's a lung cancer someday, but if someday never comes, and again, you have to put that also into the context of the patient in front of you. The patient's 45 and unbelievably healthy. That's a different story. They're 85, they had a stroke last year, right? I mean, and it's shared discussions, right? It's never just what I say and what you want and vice versa. It's let's work this through together. And then you run into the scenario too, if you've got multiple, am I supposed to just go in and snip out lots of your lung, right, to cure you of something that was never going to hurt you? That's why you get monitored. But this is all evolving. The guidelines on ground glasses have been evolving. The science behind them have been evolving. And so what I just said may not even apply 2 years from now. But they are different. They are a different beast than a solid nodule. And they're frequently not positive on PET scan. So when you have a ground glass and say, well, we're going to get a PET, don't bother. Waste of money.
And if it does evolve, we'll be sure to let everybody know.
Bingo.
Okay, yeah, sure.
That was going to be my question as well, because I also have GGOs. And my question is that I've been told that you can biopsy, but if you go like to this point, it might be cancer. If you just move over, it's not cancer.
Right.
So sometimes they don't even bother to biopsy.
Well, so there's a sampling error that's always associated with sampling anything. But you're right, if my hand is the ground glass, and maybe right in the middle of the palm is where the cancer is starting to brew, and this is all the sort of pre-cancer, and I grab all of this, but I managed to miss dead center, then I'm going to tell you, you've got a bunch of pre-cancer, but I left, the bad guy behind. But the thing will be is that even if that occurred, you're going to obviously keep getting followed on follow-up scans. Or if I prove anything looked concerning enough, we would go and cut it out. Or, depending on what the pathologist says, and depending on your scan, this is why all of these evolving ground glasses get reviewed at our tumor board, our pre-tumor board, if you will. What is the best approach? If you had a ground glass that went from 8 millimeters to 12 millimeters and has a semi-solid component, I would argue that should just go ahead and just get straight cut out. I can go biopsy what I will tell you what it is. It's lung cancer. Go get it cut out. Early stage, slow growing, but it changed. It needs to come out of you. And I mean, I'm happy to biopsy it, but there's really not much of a point. It should just come out. Now, maybe I need to go leave a marker behind. There are plenty of reasons you still may need a bronchoscopy. And depending on its location, you may still need your mediastinum staged, to sample your lymph nodes. But frequently you don't. Depends on the surgeon. Some surgeons want to know the lymph nodes no matter what. Some don't.
Yeah, well, I've had a second surgery where they did a resection, and when they, looked at the tissue, some of it was cancer and some of it wasn't.
Correct.
So it's always, it's all fascinating to me.
Yeah, no, so what you see as an abnormality on a CAT scan, not all of that represents a tumor. And even on a solid nodule. Not that whole thing is not all tumor.
I have two questions.
Please.
Number one, I have my left lung removed, left lung pneumonectomy.
Yes, sir.
More than 10 years now. So right after the surgery, my blood pressure dropped.
Yeah.
Immediately from normal, like 120 over 80, dropped to sub 100, like 90 over 60.
Wow.
So it's been like that ever since. It does affect my lifestyle a little bit. Like I don't want to pick up things from the ground.
Get lightheaded?
Yeah, suddenly stand up. It can cause some sort of a dizziness.
Yeah.
No. So I already got used to it. It didn't bother me too much. But the question is that, is this something can be explained why that is the case from your experience? Yeah,
potentially that. So when they remove an entire lung, right? So, you got two lungs and the heart sits in the middle and all the structures and vasculature sits in the middle. And they remove all that space, things expand. So the other lung expands in size and the heart shifts over. And in some cases, goes the whole way over. Either like literally kind of it's now under your armpit. Like if it was, you said it was your left lung, right? It's not always, I'd have to see your scan. But if vessels are being pulled on or nerves are getting kinked or putting pressure on, all of those affect blood pressure. So in extreme situations, it can also make the other lung hard to breathe. So in some scenarios, if they have to, not often, surgeon goes back in and sort of pushes everything back where it belongs and puts spacers in there. Essentially fills the space so that it stops shifting. So, now it's a big surgery, so it needs to, in your situation, like you said, you quote, learn to live with it. I don't know whether I would advise you to go have a massive surgery just so, but in certain situations it has to be done. But yeah, it's why we always try to avoid a pneumonectomy. They're a very challenging surgery. They're very challenging to manage, and without a doubt needs an unbelievably excellent surgeon to carry a patient through that. And that surgery gets more and more complicated the older we get.
Second question.
Yeah.
So over all these years, I've been trying to exercise,
Yeah.
increasing my right lung
Yeah.
capacity. So it helped me a lot. So I don't feel much like a short of breath anymore. But lately, I started to develop some AFib thing. Is this because I'm going too far?
Did you say hay fever?
AFib
Yeah, no, it's not.
has nothing
No,
to
the
do.
nice thing about exercise is you can't hurt your lungs. Runners talk about hitting the wall, push through it. You get crushing chest pain, please stop. You have trouble breathing, keep going to the limits of what your body will let you. You can't break your lungs with exercise.
So you're saying that the AFib, the heart AFib.
Oh, AFib.
Oh,
I
AFib.
misheard you. I apologize. I thought you said hay fever. AFib, different discussion.
Yeah.
That's a problem.
Yeah.
Is this related to my exercise, maybe pushing
Maybe.
too
No,
much?
not your exercise. So AFib, I'm not a cardiologist, I should preface all of that, but AFib happens for a lot of different reasons. Part of it can happen as part of the aging process. I don't know how old you are, but it's almost impossible to be in your 80s and not have some amount of AFib show up. It can happen, but it's just a part of life. It can happen from high blood pressure. It can happen because you were genetically predisposed to have it happen. And it may be more predisposed because of what you went through with your surgery. Now, if it's happening only with certain amounts of exercise, there are some of the drugs they use to help prevent AFib will help to limit the heart rate maximum capacity of it. But thankfully, much as there's been great developments everywhere else, the treatment of atrial fibrillation has dramatically improved. And the ability to actually cure someone of atrial fibrillation so that it doesn't keep happening. The biggest risk when you're having it the way you're having it, where it's happening intermittently, if it goes on for a while, you're at risk of forming blood clots in your heart. And then your heart goes back into regular rhythm and shoots that clot off, and you get a risk for a stroke. And so one of the reasons a lot of AFib patients are on blood thinners or now undergo a procedure to close off that part of the heart where they put essentially a blocking device in there, is so that the risk to prevent stroke. But I would, for sure, you need to see a cardiologist, but in particular, an electrophysiologist. So it's a subspecialty of cardiology. Cardiology, you've got the plumbing guys who do the cathing, but they got the electricians as well, and that's the electrophysiology. And you want it. You want an electrician.
Thank you.
Yeah. No, he doesn't need a plumber. But they'll make him see the plumber because the other thing that may be, so when people go running, right, you're exerting yourself. If we're having heart problems, we're supposed to develop crushing chest pain, right? That's what the book says, right? And I wish that was so, because it'd make everybody's job easier. But heart disease presents in lots of other ways. And your atrial fibrillation could be a sign of not ischemia, right? That would be your anginal equivalent. Instead of chest pain, you go into AFib. Maybe. So the first thing they're going to do is they're going to do a stress test on you to prove that your vessels are awesome. And then then you go see the wiring guy and prove that what's really wrong with the wiring and then see how they can fix it. But you don't want to have AFib, so go get evaluated for it, for sure. Thank you for clarifying, because I misheard.
It's very different.
As I'm
very
blowing
different.
off AFib.
Yeah, very different than hay fever and allergies. Huge thank you. I know we kept you over. I appreciate it.
My pleasure.
It's always so fun to have these conversations.
I love it.
With you. I mean, I know in my family throughout, the early stage of diagnosis and treatment and, some hiccups here and there over the last 20 some odd years, we probably grossly find humor in some of those times. But I do think it helps. It helps when we have people who are here speaking, A, at a level that people can understand, but B, to people like they're people, instead of, you're talking to them, not at them. So I appreciate you so much.
That's kind of you. Thank you.
Yeah, you're welcome. I do have to do some up next. My first up next is to wish Miss Karen, our friend Miss Karen, a very happy almost birthday. It is usually the last thing, but I wanted it to be the first thing. Anyway, Karen's birthday is on Friday. There's cake. So all of you in the room, please join us for some cake. Gathering Hope, our next Gathering Hope, September 9th at 11 a.m. Our next Living Room, September 16th. This is what I really want to kind of focus on right now. For those of you in the Bay Area, either in the room or watching, our San Francisco 5K is on September 20th. Come on out. It is such a cool day.
21st? 21st, I'm
Oh,
hearing.
you told me the 20th.
I'm hearing rumblings of 21.
Sorry, September 21st. Okay, September 21st. We used to have it up in the city, and we have it in San Mateo now to make it a little bit easier for people to come from all over the Bay Area. It's such a fun day, full of music and community and food, and some people have mimosas, I don't know. But it's a really fun time, so
It
September...
helps with the pain in the joints when you run.
Yeah. September 21st. For our friends in Philly, anybody who's watching from Philly, that 5K is September 27th, right, Katie? September 20. September 28th.
Go to the website.
And then for our friends watching in LA, this has just gone downhill. Our 5K is October 11th for sure.
And I know that's a Saturday because that's my son's birthday.
There
my
you
oldest
go.
son's birthday.
But if you haven't participated, it is a really great community event, an opportunity to meet other people, share your experiences with them, and just have a lovely few hours together. Again, thank you to Kyle, Dr. Hogarth, for coming out.
Thanks for having me.
All of you, of course. If something changes, Jane, we'll just have him come back. It'll be great. All of you watching live, post live, Penn Media for coming in and getting all of this cameras and everything set up for those of you to be able to watch at home. And of course, our supporters, and I do have to look at my paper to read this because it is a long list of people who really believe in us bringing this program to you. So Abbvie, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Novartis, Novocure, Regeneron, Summit Therapeutics, and thank you to two Summit representatives who came to join us today, and Takeda Oncology. Without their support, we could not bring this to you every month. So thank you all. If you haven't eaten, please eat, and let's have cake. Huh?
So I'll be brave if you're brave. I'll be brave, but only if you're